I would like to call Dr. Shayna Aulakh. She is a senior resident in the Government Medical College in Pattaya, and she will present differential expression of serum CXCL9 and CXCL10 in vitiligo patients and their correlation with disease severity and stability. Please.
Thank you for the kind introduction. Good morning, one and all. The title of my presentation is Differential Expression of Serum CXCL9 and 10 levels in vitiligo patients and the correlation with disease severity and stability, an Indian scenario. As we all know, vitiligo is acquired progressive loss of melanocytes from the basal layer of epidermis, which clinically manifest as achromic macules. It is a complex disease with associated genetic and environmental factors, along with metabolic and immune alterations. However, the primary defect of melanocytes, causing different morphological and functional alterations, is considered as a unifying pathogenetic mechanism. The first thought of vitiligo as an autoimmune disease came from the association of persons with vitiligo with the first-degree relatives and the first-degree relatives with other autoimmune diseases. However, recently the role of CD8 positive T cells and their effector pathways have emerged. The T helper 1 arm is the main immune arm, along with the contributions from the innate arm of immunity, T helper 17 and T helper 2 responses. The T cell response against the melan A or the MART1 antigen is selected during the T cell development in the thymus, and these T cells then cross-react with melan A or MART1 epitopes that are expressed on the surface of melanocytes. However, the star of the show in the whole process is the chemokine CXCL9 and 10. They are secreted in response to interferon gamma and act via CXC motif chemokine receptor CXCR3. These facilitate the interaction of T cells with antigen-presenting cells, leading to their increased migration towards lesional sites, causing effector and memory T cells recruited more against melanocytic antigens, thus causing rapidly progressive and severe disease. The objectives of my study was to estimate the serum levels of CXCL9 and 10 in vitiligo patients and age and sex-matched controls, and to also find a correlation between the disease severity and disease stability with CXCL9 and 10 levels respectively. It was a hospital-based single-center cross-sectional study conducted in a tertiary care center of North India in 60 vitiligo patients and 30 healthy controls. The severity score was taken as VASI and the stability assessment was done with the help of VIDA score. The patients having any known history of autoimmune pathology, acute or chronic autoinflammatory or autoinflammatory systemic or cutaneous dermatosis was excluded. The biochemical analysis was done using ELISA and the OD values were recorded kinetically at 450 nanometer with ELISA reader. The sensitivity of kits used in this process, for CXCL9 was 10.1 nanogram per liter and for CXCL10 it was 5.7 nanograms per liter. Patient characteristics and demographic profile. The age of presentation in vitiligo group was 28.72 years and in control group was 31.40. Both male and female patients were equal in both the groups. The mean duration of vitiligo in vitiligo group was 7.24 years. The mean VASI score was 11.22. And cobonerization as a clinical marker for disease activity was present in 38.33% of patients. We compared both CXCL9 and 10 levels in vitiligo patients and age and sex matched controls, and we found out that both CXCL9 and 10 were relatively higher in patients with vitiligo than in the control group, and the values were statistically highly significant. Next, we correlated these levels with the VASI score or the severity score, and we found out a positive linear correlation with both CXCL9 and 10, and that too very highly statistically significant. The next, we compared both CXCL9 and 10 with the VIDA score or the stability score. Again, a positive linear correlation was found with both the CXCL9 and 10 with the VIDA score. Then we compared the levels between segmental versus non-segmental group, and we found that the levels were higher in the patients having non-segmental vitiligo than in the segmental group. However, there was no statistical significance found between the two. To further correlate, we correlated the levels of CXCL9 and 10 with the clinical disease activity marker, that is cobonerization, and we found a linear correlation just with the CXCL9 but not with the 10, but it has also missed the level of significance by a very narrow margin. To rule out any confounding factors with disease duration, age of presentation or gender, we found no significant correlation with any of these. So from the review of literature, The present study concluded that both CXCL9 and 10 were highly statistically significant, elevated in vitiligo group than in the control group. The first study was conducted in literature by the Rashigi et al. In 2014, which found only CXCL10. However, two studies by Wang et al. In 2016 and Zhang et al. In 2019 had similar consistent results. So to conclude, both serum CXCL9 and 10 were abundantly higher in vitiligo group as compared to controls, and both rose linearly with disease severity and instability. For future, we can say that both these were higher in unstable vitiligo, thus inferring their conceivable potential as serum biomarkers to assess the disease activity. However, there is heterogeneity in results across different studies available so far, but it seemed that CXCL9, due to its higher mean values than CXCL10 and much closer association with clinical disease activity marker, that is cognerization, is the more confidential modicum for disease progression prediction. Thank you.
Any questions? Yes, Dr. Pandya.
That was a very interesting presentation.
Thank you, sir.
It's been difficult to get agreement, and the results, as you said, have been very different. So your results are kind of surprisingly, hopeful, that we might have a biomarker. But in our experience, most of the action is in the skin. It's not in the serum. And that's where most of the CXCL9, CXCL10, everything's happening in the skin. 99% of the disease is happening in the skin, and to find these in the serum has been exceedingly difficult. But I do want to just point out that we showed 10 years ago, maybe 8 years ago, that the VIDA score is not reliable at all. We asked patients the VIDA score questions, and we already knew the answer because we had pictures of their skin from 1 year previously, and their accuracy in answering the VIDA score correctly was like flipping a coin. They were wrong half the time, they were right half the time. So I recommend that for your future studies, you use the VSAS score, which is the new score that Dr. Van Giel published, in which we look at Kebner phenomenon, confetti lesions, and trichrome lesions. I think you'll find a better correlation with that than the VIDA score.
Right, sir. Thank you. Thank you, sir.
Thank you.